Good afternoon to all of our guests from the East Coast, and a good morning to those of you joining us from the West. We're delighted to host you for today's educational briefing, Putting Omnibus into Practice, counting down to September 23rd. My name is Jamie Reynolds, and I'll be the moderator for today's session. As we've all been learning over the past several weeks, Omnibus substantially modifies the HIPAA security, privacy, and enforcement rules. Today, what we hope to do is effectively summarize the changes introduced via Omnibus. Most importantly, we hope to help you focus on what you need to be doing in the next 4 months and to think through how you can integrate these new requirements into program management, compliance, and audit activities that are already underway on your summer work plan. Before we get started, we have a couple of housekeeping items. Firstly, we look forward to a Q&A at the end of this session, so please submit your questions via the chat window as you think of them. We'll get to as many questions as possible. And second, if you have any technical difficulties at any time, please notify us via the chat window, and we'll work to resolve them as quickly as possible. At this time, I'm pleased to introduce our presenter for today, Greg Michaels, Chief Security Officer for BluePrint Healthcare IT. Greg brings nearly 15 years of experience in information security program management. Prior to joining BluePrint, Greg worked as a security analyst for i3 Global, a clinical research organization subsidiary of Ingenix, now Optum Health, and United Health Group. Prior to i3 Global, Greg worked as a network and security analyst for PXRE Group, a Bermuda-based reinsurance company. Greg holds a bachelor's degree in biological sciences from Rutgers University, a master's degree in network security from Capital College, and a master's degree in health science and technology law from Seton Hall Law School. Greg holds a number of certifications, including CISSP, CISM, CISA, EMP, CBCP, and he is a high-trust common security framework practitioner. Greg also volunteers on the National HIMSS and New Jersey HIMSS Security and Privacy Task Forces. Adding some color commentary to our session today is Stephanie Crabb, who is Vice President of Client Development for BluePrint. Prior to joining BluePrint in 2002, Stephanie worked for CTG Health Solutions in various client service and business development roles, including leading the launch of CTG's global information security practice. From 2005 to 2012, Stephanie served as VP of Client Services for Synergistech, where she was responsible for sales, marketing, client service, and new solution development. So at this time, I am going to pass this over to Greg. The floor is yours.
Thank you, Jamie. Hello, everybody. Thank you for joining today's webinar. We're going to be focusing on the recent changes brought about by the HIPAA Omnibus rule. And here's a brief agenda here. We'll go into a little bit of introduction, then we'll really get into the nuts and bolts of the Omnibus rule and the changes and what those changes mean for healthcare organizations. And then we'll talk about next steps. And I'm going to work on leaving plenty of time for Q&A because we do have a lot of attendees today, so I certainly want to allow some time for us to discuss other questions that your organization may have. So today we're going to introduce the Omnibus rule. We're going to review the details of the most important changes. We'll provide some guidance on how we can meet these requirements, and then we'll look at some of the critical components of the security and compliance program and offer some guidance on how to better protect patient information. Okay. So just to look at some dates here, we're in the effective period now. This rule was effective March 26th, and the compliance date that we all are striving to meet here is September 23rd, 2013. So we do have some time, but it's certainly going to be somewhat of a time crunch, especially with some of the business associate requirements and some of the things that we'll need to make sure that we have in place. Okay. The Omnibus rule does make some changes to the HIPAA security rule, the HIPAA privacy rule, the breach notification rule, and the enforcement rules. So it really affects all of HIPAA, and we're going to jump into this right now. I'm going to start with breach notification. I think this is one of the biggest changes that we want to take a look at, and we want to make sure that we cover this and we outline what has changed and what that means for different types of healthcare organizations. Okay, so HITECH Act came out in 2009, and this really brought some stringency to HIPAA and really brought some enforcement about it. And we've been waiting for the final rule for some time. Now it's here, and the compliance requirements have certainly increased dramatically, and the penalties have increased, and the responsibility for HHS to really regulate covered entities as well as business associates. This has all happened on the federal level, but we always want to, start with a caution here. The individual states, most of them have their own set of breach notification laws, and they center around generally personally identifiable information, or PII. So we always want to look at our incident response plan, and we want to make sure that we're focused both on the federal requirements as well as the individual state requirements that we need to meet. Okay. So for breach notification, it's really contingent here upon the discovery of a breach of unsecured protected health information. Covered entity or business associate, they have different requirements. The covered entity is really the one responsible for having to do the notification outward to HHS as well as the victims of the breach. But business associates also have their own set of responsibilities here, in that they need to really ensure that they let the covered entity know within a reasonable period of time. For breaches that are over 500 records, we're really looking at a period of 60 days at most. So there is really a responsibility for healthcare organizations to be able to detect these incidents and to go through an investigation process to determine what notification requirements there are. So when we define a breach, we're really looking at a breach as being an unauthorized acquisition, access, or use or disclosure of unsecured PHI. Right? Unsecured PHI is defined as PHI which is unencrypted or not destroyed properly. So those are the real safe harbors. We can get around the breach notification requirements if we provide an adequate level of encryption on our protected health information. And we can also, at the end of life for that information, if we can go through the proper destruction procedures, then that gives us our safe harbor. Okay? So how did Omnibus change breach notification? When breach notification first came out, the organization was permitted to do what was called a harm assessment, where they could go in and take a look at the incident, and if they would really have to prove that that incident had the potential to cause a significant risk of harm. So kind of the innocent until proven guilty theory. Under Omnibus, an impermissible use or disclosure of PHI is presumed to be a breach unless there is a low probability that PHI has been compromised. So now we're kind of presuming guilt, and we have to work to show that it's not a breach. Documentation, of course, is extremely important, and the incident management process really needs to be documented from detection all the way through whatever response or notification needs to come out. I think the more documentation, the better, and we've seen these in a lot of the breach investigations as well as a lot of the OCR audits. A compromise is not really defined in HIPAA, but in the preamble, it's mentioned as inappropriately viewed, redisclosed, or otherwise misused. Okay. So I think this is it's a good guidance point here. We're really looking at if the information is viewed or accessed by an unauthorized individual, then we need to treat that as a breach. Okay. I kind of touched on timing of notification before, but I definitely want to kind of reiterate this here. For any of these breaches, notification out to the victims needs to be done without unreasonable delay. So that 60-day guideline is really a maximum. Okay, we really want to be able to go through that investigation, determine what we need to do much quicker than this. I think the quicker the better, and that's going to really show that level of due diligence and really show that our incident management program is at the top of its game. Another important point here, I think, is that using reasonable diligence, the entity would have known about the breach. Okay, this is a good guideline because what Omnibus and what the breach notification rule has really come out and stressed in this is that if your organization is not doing any type of monitoring and does not find out about a breach, that may not be good enough. It's not good enough to say, well, I didn't know. It's really important that as an organization during or within this incident management process that you can show that you had the proper controls in place, that you had the proper monitoring or auditing procedures in place so that you could reasonably detect when an incident occurs. Okay? So that's very important to know, and I think that will really go a long way in terms of lowering the risk for when these breaches do occur. Okay. So we'll look at this. Organizations, of course, still have the ability to go through and do that risk assessment upon discovering a breach. Okay. There are some guidelines here, and again, I stress documentation, making sure that there's a consistent process for this, making sure that it's centralized so that incidents are managed the same way every time. We really want to look at the nature and extent of the PHI, okay, including the likelihood of re-identification. And this is another thing that's very important because de-identified information, while it's not considered to be PHI under HIPAA, it seems that there are always new methods out there where de-identified information can be re-identified. So it is important to make sure that we're really looking at the latest guidance in terms of de-identification and making sure that that fits into our overall security management program. We want to look at who the unauthorized person was that may have accessed this information. So does the unauthorized person have a duty to protect the information? If it's another covered entity or it's a business associate that falls under HIPAA, then that may be enough to prove a low probability of harm. Okay. Whether the PHI was acquired or viewed, we certainly want to look at, what was the actual opportunity for this information to be accessed? Was it feasible? And then we want to look at the extent to which the risk has been mitigated. So what controls do we have in place to detect? What controls do we have in place to reduce the risk? And what procedures did we take through our incident management program to really reduce the likelihood that that PHI will be either further used or disclosed, or that a similar type of breach would occur? All right, so what should we be doing now? And I think that I'm going to let Stephanie talk to a couple of these slides, and then I'll resume with some of the other content.
Right. So can you all hear me?
Yes, we can.
Okay, fantastic. So what should you all be doing now? And this is really tactical planning for these next 4 months. document and refresh that breach risk assessment process. Believe it or not, we come into contact with organizations every day that don't have a well-documented breach risk assessment process. And we're talking about a documentation effort like Greg is talking about in terms of a well-articulated checklist so that a suspected incident can actually be walked through and well documented. And if you do have that process documented, go back and redocument some of your old incidents using a new process for practice. So if you've gone back and refreshed it, take a chance and go through and redocument some old incidents just for practice. And if you haven't had documentation in place, go back and take some things that maybe you've seen hypothetically in journals or white papers or from some of your compliance colleagues or privacy and security officers who are willing to, share some of their scenarios and take your team through some practice. Review and revise your breach notification policies and procedures. Again, we were at the HCCA conference a couple of weeks ago, and this was a lot of what we heard compliance officers and the privacy and security officers who were there talking about, that they were in the throes of going back through and refreshing and updating their policies and procedures. So don't delay on that. Take a working session with your multidisciplinary team and knock this out and get it done and get it through your own corporate adoption process. Greg mentioned the incident response plan and procedures. As you all know, incident response is probably much larger than any one of you and the discipline that you work in. We've got compliance officers on this webinar today. We've got general counsels on today's call. We've got auditors on today's call. We've got IT folks on today's call, and privacy and security officers and others. Incident response really is a multidisciplinary effort. And so the idea here is to make sure that your incident response team is in fact multidisciplinary, that you have the right people involved, and again, similar to the breach risk assessment process, prepare the team and practice. So again, take some of those hypothetical scenarios, get the team together, go through sort of a tabletop exercise, and practice any of those review or revised plans and procedures and make sure everybody's comfortable with them. Workforce training is another point of refresh. One of the things that has come up, and if you all are in any of the LinkedIn groups or in any of the HCCA net groups, there have been a lot of dialogue going around about how do we update, our workforce training. It's really around these three areas: how to avoid breaches in the first place, how to train your workforce to alert a team to alert to potential breaches, and how they should respond, if there is a suspected breach. And this is everything from a practice administrator in a physician office, if they get a fax mistakenly, and what to do immediately if they do that, to a department notification, to somebody overhearing or seeing something transpire, to a misuse of a password. We know that these things continue to happen in our environments every day. So it's about acculturating every member of the workforce to sort of nip these things in the bud, and how they can go about keeping a lid on these things and reporting them correctly when they see them happen. So get granular on this and take this sort of new information that comes out of Omnibus to the workforce, very quickly, and update your training. And then finally, the things that you can be doing to mitigate this exposure. Greg mentioned safe harbor and following those things in encryption and destruction, certainly. And then for those of you who are involved in the compliance activities as well as in privacy and security monitoring, there's no doubt that the things that you can do from a technical standpoint to raise the level of your game in terms of proactive monitoring, make all of the difference. At HCCA, it was very interesting. in Mr. Rodriguez's presentation, there was a question raised about encryption projects and some of the frustration about the slowness to get some of these things done. And he really pointed to willful neglect at the pace at which some of the encryption projects have been getting done at the expense of some other things. The idea here is use Omnibus to help put a spotlight on some of these things that maybe have been lingering from a remediation perspective, and make those projects your friend to mitigate some of this risk.
Great. Thank you, Stephanie. Okay, so the next big change with Omnibus is the liability that business associates have, and the fact that business associates are now covered under the HIPAA rules. Okay, so there's been a slight definition change for business associate, and some of the newer types of business associates have been included in that definition. So this list here is certainly one to take a look at. Another important thing is subcontractors of the business associates are considered business associates as well. So there is this chain, and there is a requirement that the business associate agreement be included everywhere down that chain. I've even seen some organizations that within their business associate agreement, they mandate that their business associates do not use subcontractors to sort of reduce this risk. Okay, so business associates are directly liable for meeting the HIPAA security rule and portions of the privacy rule. Okay, but HIPAA security rule, absolutely, and that's something that is very important and should be reflected within the business associate agreement. They're directly liable for impermissible uses and disclosures, including breaches. Right? They must provide the covered entity with notice of a breach if it's the business associate that suffers the breach. Okay? Provide PHI where required to the secretary to investigate the business associates. What we really want to do as covered entities here is we really want to make sure that our business associates are aware of what their responsibilities are, and really want to guide that incident response process or that any security requirements that are in place, so that the business associate is well aware of what they need to do. And then on the business associate perspective, we really want to make sure that we are going out there, we're taking the proactive steps to maintain or to obtain compliance with the HIPAA security rule requirements, and that we are proactively monitoring our networks so that we can then go out there and be able to notify the covered entity of any breach, and then hopefully work together in terms of that investigation. Okay. Business associate agreements. This is something that's definitely very important, and should we want to be as clear as possible in terms of what requirements the business associates have, and we want to really go through and kind of offer that guideline or that guidance. I think a lot of times business associates have not really been covered by HIPAA until HITECH and some of these other changes have come out. So this is certainly an area where I think the covered entity can offer some assistance. And some of the things that we put in here that should go into that business associate agreement. We certainly want to talk about HIPAA and meeting the administrative, technical, and physical safeguards required by the rule. We certainly want to talk about a right to audit, so that if there is an incident, the covered entity can go in and provide assistance for the business associate. We also want to make sure that if the business associate is storing information, that at the end of the contract or the end of the life cycle for that information, that it's properly destroyed or returned back to the covered entity. Okay.
So with respect to your business associates, what should you be doing right now? first and foremost, this has been a real challenge. Identifying and inventorying who our business associates are, I think, is a universal challenge. And we hear that, again, all the time. But now is the time to really get a handle on who those organizations are. And, not all of our vendors are business associates. And so it's time to define that universe. And even within that universe, not all business associates are created equal. Updating our business associate agreements yet again, and that supporting documentation that Greg mentioned is exactly right. Because, again, not all BAs are created equal. So we suggest, and what's becoming a bit more universal and across the industry, is segmenting those business associates into categories or tiers based on real or presumed risk, in many of the same ways that our IT organizations segment and classify systems based on risk. So the idea is that you can then begin to develop those business associate agreements or supporting documents or terms and conditions based on the kind of business relationship that you have with that business associate. We are not going, to tackle that entire universe, in the first several months. Start with the highest risk organizations, those that you have the most robust data sharing relationship with, and work, systematically down that risk chain to the business associates that present the lowest risk. This is exactly what we saw in the OCR audit process. We had a couple of our clients who were audited during the OCR audit process, and this is exactly what the OCR looked for. They asked for a sampling of our clients' business associate agreements, and they asked specifically to look at any of the special terms that they had put in place with those business associates based on the kind of relationship that they had. In one of our client scenarios, they were able to show that they had introduced some specific terms and conditions based on the relationship that they had. In one of our other client scenarios, they weren't able to do that. They had a one-size-fits-all, business associate agreement, and they had a deficient finding, based on that fact. So this really is supported by, what the OCR is looking for, and clearly is reinforced, under the Omnibus rule. So implementing that plan, looking for opportunities to introduce some more rigor into that relationship, is our recommended course of action, and again, is certainly becoming a more widespread practice. Implementing a centralized management strategy for these contracts and your business associate agreements. Many organizations have some sort of, contract management module, but maybe just the contract has been living there and the business associate agreements and supporting documentation haven't quite gotten there. Again, use this as an opportunity to try to start. And again, you may not get them all there, but at least try to get those high-risk vendors identified and those business associate agreements there. And then proactively monitor as much as possible for those breaches and audit access, to PHI for those relationships, again, that are on that top 10 list. Start with some, whether that's 5, whether that's 10, try to make an effort with at least some, portion of your business associate community. Now, for those of you on the call that are business associates, we don't just want to, throw the hammer down, for you. We know you all have a lot of pain in this process as well. We hear from you too, and we know that you all are every day. We hear that you all are getting dozens and dozens of unique requirements from your provider client organizations with their unique requirements of you, and you're trying to do your best to support your clients who are very important to your business. Be proactive. Document your HIPAA high-tech compliance posture. Create a client-ready consumable that you can share. Either push that out proactively or make sure you have something ready on demand that you can share with your provider organizations to show the action, the steps that you've taken to be compliant with HIPAA and high-tech. Consider engaging a third-party consultant. whether that's us, whether that's someone else. This isn't an infomercial for BluePrint, but there's no doubt with the provider organizations that we've worked with over the last 10 years, their trust level in you increases if you work with an independent third party. That has been demonstrated time and time again. If you can show a third-party validation, that really goes a long way with the provider organizations. So that might be something to consider. Anticipate the volume of new documentation that will be coming from your provider clients. Even though there's some leeway there with that documentation that was either created before or after January 25th or March, just make sure that you've got adequate resources on your end to support the document review process that most certainly will be forthcoming if it hasn't hit you already and will certainly continue into the next year. Your timely response to this documentation, coming from the provider organizations, is going to make a difference in that client service relationship that you have with your provider organization clients and business partners. And anticipate that your provider clients are going to have new requirements for you. That was, on Greg's slide, you saw some of the things that consultancies like ours are certainly recommending to our provider clients. Their general counsel's making those recommendations to them. Other consultancies are making those recommendations. They're going to require more of you via that BAA. Those things might be that you document for them or attest for them that you are conducting a HIPAA risk assessment annually. They may ask you to provide access control audit reports for the staff on your team that are accessing their systems, training reports of your staff that interact with them that touch PHI or EPHI. This might create the need for new negotiations, new contract negotiations. This might have a significant impact on your cost of doing business that you might have to introduce. The downstream effects for your compliance with HIPAA and high-tech can't be underestimated. And for those provider organizations on the call today, understand that this does have real impact, for your business associate partners as well. This really has to be shared governance, and there's shared risk now, in this model, for you. And, this is coming, this is not, something that's going to live in materials management or supply chain or contracting. Those of you in the compliance space know that you probably are going to get pulled in more and more to, where the pushes and pulls and tensions and cooperation is going to have to live. So this relationship is going to change now that business associates have these new responsibilities, and these are some of the implications for this relationship.
Okay, thanks. And that was a great point Stephanie brought up in terms of the collaboration that's really needed. We see a lot of clients that have these kind of siloed departments: privacy, security, IT, risk, compliance. And I think that these changes are really consolidating the work involved and giving us a great opportunity to work more closely together and to really have an outreach program or a steering committee of some sort where we can go out and really get the stakeholders from the entire organization, including the clinical side, where we can get them in and really work with them and reach out to the business associates as well and help them to become more compliant and to meet these requirements. I'll go through some of the enforcement stuff. I think that this has been out there for some time now, but I do want to highlight a few things. Obviously, high-tech significantly strengthened HIPAA enforcement and gave HHS and OCR, as well as the state attorneys general, to more power in terms of how they can go out and enforce this. The enforcement rule applies to covered entities and to business associates. So, we're kind of all in the same game together now. Willful neglect. This is in red for a reason. This is the place you don't want to go. You'll see on a subsequent slide here, how the penalties get dramatically greater with this willful neglect. But willful neglect is really not making any effort to do the things that are required by HIPAA and to really kind of use that, well, I didn't know about it approach. And I think that was an old theory that really doesn't apply to HIPAA and the new enforcement rules anymore. So willful neglect, the conscious, intentional failure or reckless indifference to the obligation. This has been made very clear, and OCR is mandated to investigate any potential willful neglect violations.
I want to add something about willful neglect, again, because this was a topic that was explored pretty significantly at HCCA, both formally and I'd say a lot in sidebar conversations. And it came up in the context of organizations that are receiving meaningful use dollars. And there's been a lot about this in a lot of the blogs and social media and things like that as well. And it really creates a very interesting discussion around organizations that have used their business justification for not implementing certain programs or certain controls with respect to any of the implementation specifications, particularly in the security rule, because of funding, right? And so now that organizations have been receiving stimulus under Meaningful Use Stage 1, those organizations that in their remediation plans and justifications and risk assessments that have been using funding or lack of funding as part of their business justification, it is a real challenge now to use that if you have been receiving stimulus funds under meaningful use. Because, as you all know, with mandatory 14 or 15, as you submit your risk analysis and you speak to your posture with respect to your risk analysis and your remediation plan, and you've got to document that and demonstrate that as part of your attestation. And if you have some of these things coming up and you say, well, we haven't done that because of lack of funding, that becomes a real conundrum. So I, really, implore you all to make sure if you have used that as part of your business justification for an inability to implement something along the lines of the HIPAA security rule or a program with respect to the privacy rule, and you are a meaningful user and you have received stimulus, crosswalk that back with your risk management committee. This is something that if you get audited under Meaningful Use Stage 1, what those audits have commenced, and it's just something that you're going to want to tie back. Make sure that you have real tight documentation and that's crosswalked all the way through, because this is not something that you potentially want to get tripped up on and have that be somehow tied back to some sort of willful neglect potential trip up from the OCR.
Yeah, great point, Stephanie. So with this, we can obviously see how the penalties get greater. I think two of the most important things here. The first one, did not know. Covered entity was unaware and could not have known if exercised reasonable diligence. So there is a basic level of due diligence that really is expected. If an organization just did not know. I mean, they have to be doing something, and it has to be something that they couldn't have reasonably noticed or monitored or detected. And then we look at the willful neglect categories down here, and there is a spot for willful neglect that was corrected, which means that once the incident happened, the violation or the cause of the violation was corrected within 30 days. So just that level of due diligence and effort will go a long way in helping to reduce any penalties. Right. Some other miscellaneous things here. The notice of privacy practices, and this is typically under the privacy officer. but certainly can fall under compliance or some of the other areas. There are a number of changes that are required, and some of the big changes here are ensuring that there is mention of any marketing or fundraising or sale of PHI that is done, and really giving the patient the means to opt out if there are going to be marketing or any fundraising type activities, that there's a clear instruction set for how that person can opt out of receiving these types of communications. So we're really getting to the point where the patient is going to have more rights with how their information is maintained by the healthcare organizations that maintain it. Right? Talk about right of access here. With meaningful use, I think that we got a lot of this, really created these procedures to provide the patient with a copy of their electronic medical records. So I think that we're pretty good here, but we really want to be careful with our uses and disclosures. So updating those policies and making sure that there's really good procedures in place so that if we are disclosing this information to other healthcare organizations or other entities, business associates, that we have a good process for doing it and that we're only disclosing the minimum necessary amount of information. We don't need to send the entire patient record for every single transaction. A right of restriction. Now, this is more for the health plans on the call and the covered entities, but what we really want to stress here is that the patient can and does have the ability to restrict this information. So if the patient is paying out of pocket, then they can request that their information not be sent to a health plan. I think that's something that is important to know, and procedures should be put in place so that we can go out and meet this requirement. I think a lot of this is going to be more and more important as we start this greater exchange and sharing of information through ACOs or HIEs. There's a lot more disclosures that will be taking place, and it will be much easier for different types of organizations to access this completely electronic information. And I think that this is one area that we really want to spend some time on, sit down and discuss what information we want to share, how we're going to share that information, and really document that authorization and consent process so that we know that when we're disclosing information that it's being disclosed because it's really necessary for that patient's care, and that's why we're going out and disclosing the information. Okay. I won't go into this a lot, but genetic information falls under the definition of health information. Health plans are prohibited from disclosing genetic information for underwriting purposes. And so I think this will come into play a lot as we start getting into personalized medicine and population health management and some of this stuff where we're really looking at diseases and the different types of individuals that can be affected by these diseases. Research. So for any of these organizations that are doing research or for any separate research organizations, again, we really want to make sure that we have authorization and consent and we have those processes very well documented. And the last point here, patient information is not considered to be PHI any longer 50 years after a person's death. This may or may not have much of an effect, but after 50 years following the death of a patient, the information no longer needs to be protected and no longer falls under HIPAA. So, to summarize this, where should we be spending our energy and resources? Breach risk assessment. Stephanie did a great job before of talking about the breach risk process, the new requirements, the incident management procedures that we really need to have in place, and the documentation that we have. Business associate management, okay? Looking at those high-risk vendors, centralizing the contracting, the BAA process, and really providing the assistance necessary so that when our information is going out to a business associate, that it is being maintained and protected at the same level that it is within the provider organization or healthcare organization. Training and awareness is always key. Security risk is always going to be there, and the more that our entire organization knows about why it's important and what is important to do, the greater that level of protection will be. Proactive, continuous security management programs. It's not really good enough to go out there and implement something, do your risk analysis, and then let it go. So it really needs to be a continuous focus and a process. We just build this into our organization where we're continuously assessing risk and we're continually reducing that level of risk to acceptable levels for our organization. Okay? We have about 4 months to comply. We definitely need to take a look at those policies and procedures and make sure that those are in place. These are the first things that are requested by any auditor that comes in: policies, procedures, and the risk analysis. So, these are very important to make sure that we have these up to date. And then as we get those processes in place, then we can start looking at some of these technical security controls that can really help automate and make our lives easier. Encryption is very, very important. I think is one of the very low-hanging fruit. Get those portable devices, those laptops, those mobile devices, USB keys, and make sure that information is encrypted if it's on those devices. Vulnerability testing, so doing some type of proactive quarterly, annually, twice annually, whatever, but put a process in place to go out and take a look at those vulnerabilities and really do an assessment on them. Patching your systems, making sure that all those updates are loaded on a proactive basis. Data loss prevention is a great tool, along with intrusion detection or prevention systems, for monitoring the network and really providing visibility into what is going on and how this information is being used and accessed. Log management systems are great for providing that audit trail. And mobile device management. There's a lot of new solutions have come out and I think have really taken a big step in terms of how are we going to manage the mobile devices that we own, and how are we going to manage the devices that are being brought in by the user community out there. Okay, and with that, I want to thank everybody for joining the call, and I will kind of turn it back over to Jamie for now, and we'll see if we have any questions.
We sure do.
You can also type questions into the chat box as well.
Yeah, so this is Steph, and I've got sort of part of the control of the chat box, as does Jamie. So I'll start with the first one here, and this is from Noah M., who writes, I represent an organization that is often contracted to provide direct services to client by county, state, or federal programs. I believe in many ways we are both a covered entity, a direct behavioral service provider, and a business associate, subcontractor of administrative body / funding source. How do you recommend we develop our security and privacy posture? As a covered entity, a business associate, or both?
That's a loaded question there. Well, my first thought here is, I think that the covered entity, first of all, will have a greater obligation to meet the standards, because the covered entity is going to be subject to the complete security rule as well as the complete privacy rule. So I would focus on that. Overall, I think the requirements for the security rule and the privacy rule are the same, so I'm not sure that it makes that much of a difference in terms of that, but I would definitely want to comply with the entire HIPAA rule. I'd want to make sure that that's there, and with the privacy policies and procedures, I would absolutely, with having behavioral health type information, I would certainly want to focus on that SAMHSA information and the highly sensitive information and make sure that I have really clear consent processes in place.
Thanks, Greg. Jamie, I think you've got a couple that you're tracking.
Thank you. I actually see another one on here from Noah M. Has the section of the omnibus regarding enforcement changed OCR's obligations when they receive or their process for determining the validity of complaints against agencies? Will any complaint trigger an audit?
I think that more and more we're going to find that complaints are absolutely investigated. I did mention earlier in the slides that if willful neglect is suspected, then OCR is mandated to do an investigation. So I do think that when these potential incidents are reported, we saw it in that Arizona physician practice case where somebody reported that information could be accessed through a web portal, and there was an investigation and a subsequent fine. So, I would absolutely expect that complaints are going to be investigated as much as possible, and certainly on anything that approaches willful neglect.
Yeah, I think at HCCA, Director Rodriguez suggested that 100% of complaints are receiving follow-up from OCR. So they're creating a culture, within OCR for, the community that at least at some level, and I think this is to sort of really reinforce confidence, especially around, privacy and such within the community at large, that, complaints are taken seriously. And now, great, not every complaint, of course, leads to a finding, but that, complaints are something that are taken very seriously within the agency. So if that is, if that in fact does hold true, if that's the practice and the behavior of the agency, then I take that, I take him at his word in face value that 100% of complaints are in fact getting some level of attention from OCR.
Thank you, Stephanie and Greg. We do have another one here. We're a small hospital, and we have a business associate agreement with all of our vendors because it was easier to make sure we were not forgetting anyone. Do we need to change our practice under the new Omnibus rule?
I think that with the Omnibus rule and the new requirements here, I would taken from Stephanie's discussion before, I would absolutely take a good look and do a very thorough inventory of who my business associates are and really look at them and make a determination. If there are entities out there that don't really fall under the business associate definition, then I would try to really eliminate that as a process, especially for small organizations where each business associate that you need to manage, that's time, resources, and essentially money. So I would absolutely want to limit that business associate pool as much as I could.
Thank you, Greg.
Thanks, Greg. Here's a question from Jill R. You said the requirement to comply with a request for restriction with respect to prepaying for services applies only to health plans. So if we are a physician group practice, we're not obligated to comply with the request?
No, I think that I think maybe that was misstated. Really, what that means there is if a patient requests, and the request is going to be made to the provider, if the patient requests that the information is not sent to a health plan, then the patient has the right to do so if they are paying out of pocket. So it is the provider that needs to grant that request.
Right. So as the physician practice, you wouldn't report, you would not disclose that information to the health plan. So you are obligated to comply with the patient's request to not notify the health plan of that service that was provided. Of course, as we said, the tricky part of that is if that service is part of a larger bundle and things like that, it is something that, we know organizations are really wrestling with. And there are going to be some instances where that to tease that out is going to be very, very difficult. And that's why this is, again, for those of you who are, compliance officers and things like that, this is not uniquely your problem to solve. You really have to work with your counterparts in HIM and in coding and billing and all of these other areas to really figure out how this is going to be possible. I think maybe you've got another one, Jamie?
I do indeed, and this is coming from John T. Can you give me an example of how we can practice our incident response plan?
Yeah, that's a great question right there. We mentioned tabletop exercises in the presentation, but I think that what I would really want to do is I would want to sit down with my steering committee or whoever's really looking at these incident management processes and making decisions, and I would want to list out the most likely scenarios that could affect our organization. Where do we think we're most at risk for having a breach? And then I would want to go through the procedures for how we would deal with each one of those particular incidents and who would be involved and who would need to be contacted and what the communication process is like. So I think that's what I'd want to do because each organization is going to be different and the risk for a breach is going to be different for each type of organization. So really take a look at those processes, take a look at what controls you have in place, and go through that exercise on a regular basis because the risk for incidents and for breaches will really change as we move into new areas of healthcare reform. For example, HIE, we start sharing information and we're exponentially increasing our risk because more entities will have access to that information.
Great, thank you. And on top of that question, is it your recommendation that we document a breach risk assessment for each suspected breach?
Absolutely. Absolutely is the answer to that. I would document every step that I took from detection all the way through notification or whatever the outcome is. But I would absolutely want to make sure that I have everything documented so that if there ever is an investigation or an audit, that we can really show that, look, we're meeting that level of due diligence. This is, we have the processes in place, we have the controls in place, this is what we're doing, and I think I'd want to absolutely highlight that.
Great, thank you. Another one coming in, Bill P. A lot of BAs are bigger than we are. What new conditions that we introduce can we reasonably expect them to agree to?
Yeah, that's a tricky one, I think that I've certainly seen organizations that are getting pushback from some of the especially larger business associates, but I do think that it's important to start high, put in all those requirements, and then each organization is going to have to go through that negotiation process and really make a determination of what they must have in that business associate, what they need that business associate to agree to, and what they could, potentially compromise on. And, if the business associate doesn't want to do any of it, then, at worst case scenario, you might have to look at a different business associate.
And the other thing about that, too, is remember, you may be just one provider, but, many other of your colleagues, are asking the same thing. And, we're also starting to see groups coming together, and some of these things are coming through GPOs or through special interest groups or other sort of consortia. And so that's the other thing as well. You all have sort of your cohorts and other groups together to bounce ideas off of. I even, heard that, there are some, groups through sort of the AHLA and things like that where, parties are starting to come together to see if there's sort of some standard, terms, conditions, asks, expectations that might start to coalesce. So, I think keep your eye on some of that, or maybe start to see where there's some brokerages that are coming together for some of these, common terms, common expectations. Even though you might just be one, remember, you're one of a very large collective of provider entities. But you're right. I think on the whole, if we had some standards of practice, you wouldn't feel so alone out there, pushing the rock up the hill by yourself. I think we've got time for a couple more, and then we'll adjourn. This is from William B. Is it more important to have processes that people know well, or documentation? Boy, that's the age-old question.
Right. Does the process exist if it's not documented?
Yeah.
I think that both are certainly important. I think from a from a security management program, having the process in place is certainly better than having documentation. But then again, from the audit perspective, documentation is going to be just as important. So, I really think that I see a lot of organizations out there that have the process but haven't documented it yet. And, I think that you're just leaving the door open for, some type of penalty or some type of negative audit finding or something like that. So I do definitely want to stress the importance of both. And I think that, where your organization is seeing a lack of documentation, I think that's something that should be on the 2013 roadmap for these are the things that I have to do.
Yeah, no doubt about it. And that was, again, absolutely validated by the OCR audit process. Organizations certainly were acknowledged if they had the processes in place, but if the documentation wasn't there where it allowed really knowledge transference and the culture of compliance to be seeded, more deeply across the organization, then they certainly had a finding of deficiency. Well, I think we are at 2:02. So, Jamie, I think we can adjourn if you want to wrap us up.
Absolutely. I want to thank everyone for taking the time to spend with us today. If you have any further questions, our contact details are on the back end of this slide, and feel free to don't hesitate to reach out to us with any questions or comments following this webinar. But again, I thank you for your time, and we look forward to hearing back from you shortly.
Just know we will be sending out the slides and this recorded presentation to everyone next week. So we encourage you to please share that with friends, colleagues, etc. And you can look forward to receiving that from us next week. Thank you all so much. Enjoy the rest of your day.
Thank you.
Bye-bye.